You are live now.
So good evening, everyone. As you all know, you have been enrolled for this contactless learning course program, but we have covered almost all aspects of contactless so far. So today we are going to cover one important topic, and those who practice contactless, they must be aware of this field also, which is dry eye. And for today's topic, we have fortunately got somebody who has excellent experience in dry eye ocular surface, and the most important is she's a very good teacher, speaker, and also she has done a lot of innovations in this field. So I hope today's lecture will not only give you a basic idea about what is dry eye, but also stimulate you guys to do some more research, come out with new things, and that will help you a lot in your practice also. And since a lot of you are practitioners from Delhi, so I think you can ask specific questions like always you keep on asking where to do this test, where to do that test. You can put the question in your platform and I'll communicate that to our speaker, Dr. Pooja. And with this, Dr. Pooja, I would like to invite you to please start your talk and we'll discuss what your lecture is.
Thank you, Dr. Praful, for inviting me and giving me the platform to share our experience on dry eye and ocular surface. I think, Mr. Sharik, you need to stop sharing the screen. Okay, thank you. So, thank you for inviting and giving me the platform. And what I thought was it's like we'll make it a little bit of everything, starting from basic to what the current advances in dry eye and ocular surface are. And hence the topic of dry eye decoded in terms of science, sensors, and solutions, because it's going to be a framework to therapy. And at the outset, I have no financial interest, but whatever I'm going to be speaking is either based on literature or the experience what we've been having. So the entire presentation is going to be divided into the 7 aspects of overview, the diagnostic algorithm, the management algorithm, the therapeutic modules, case scenarios, what is the future, and ending with summaries and takeaways. So this is how the presentation is going to be divided by. So we all know that, dry eye is kind of becoming a pandemic, and the burden of dry eye globally or in India is also as good as maybe 30%. It can be based on geography and the diagnostic criteria. In India, it's even more higher because now we have a lot of IT professionals who are heavy screen users, and though the ideal time of the screens would be 8 hours with a good health hygiene of screen hygiene, they still sometimes we get a lot of patients, 50% of the patients, they say that they are on the screens for almost 12 to 14 hours, be it televisions, mobiles, or computers. And in India we also have a dusty or hot climate, pollution, a lot of contact lens users, so it's just we are technically dealing with a pandemic when it comes to dry eye disease. And it's not just a global burden when it comes to when your daily life and productivity is affected, but it is also in India where because of the digital eye strain or because of pollution or hot climate or any other autoimmune diseases, as many as 30% of the patients do suffer from dry eye. And sometimes because of the lack of proper therapy they take, the quality of life also gets affected. And it is now becoming, the when if even if you look at the health and ergonomic perspective, it's also taking a toll on the the monetary ways, because as many as 55 billion dollars are being spent on the treatment of dry eye, and the productivity loss also contributes to almost 70 to 80% of the economic impact. So it is not just we are treating with a disease, but we are also have to be concerned about the ergonomics when it comes to the dry eye disease. The second most important thing why we have to think about it is lot of patients who do not have a known history of dry eye, when we operate either a cataract or refractive surgery, post surgery, they start complaining of suboptimal vision. Even if the surgery has been perfect, you've put the best of IOLs, a lot of patients are not happy with the quality of vision or the quality of life. And we only think that probably the surgery is a problem. But ideally, if you look at it in detail, it's not the surgery, but probably it's a subclinical dry eye, what we have missed. And that's why the patients are unhappy post operatively. So, along with, and we do have a lot of contact lens users also, and we know that contact lenses can also impact the dry eye and ocular surface. So we have to, and a lot of refractive surgery patients are contact lens users. So we have to look at dry eye in detail before surgery as well to improvise the outcomes of this thing. So, when I was looking at most advanced things of the dry eye, what we should be speaking about from a practical and clinical angle, we all are aware that recently DUCE 3 was launched, and DUCE 2 was introduced in 2017, but in 2025 we now have DUCE 3. So, we have to, because the algorithms are updating in terms of diagnostics and management, our treatment also will be updating. And one of the good things what they have done in the DUCE 3 is DUCE 3 was just the foundational work. It was more flexible. The treatment was staged and stepwise. But however, in DUCE 3, they have emphasized on how to diagnose and treat it precisely. Basically, they have gone based on the algorithm, tree-based treatments and diagnosis, the driver-based, the evidence-rich, and personalized care. So DUCE 3, they speak more and more about how from diagnostics and various therapeutics available, we can give a personalized care to our patients compared to what we were doing before. And we have now more and more robust cutoffs when it comes to diagnostics and subclassification as well. And these are just the few highlights of how it's different, not only in based on diagnostics or subclassification or management perspective, but they have also started looking at the lifestyle, the environment, which we just spoke about in the introduction. There is a stronger scientific foundation because now they are not only looking at the Western population, but they have also considered the Asian population into consideration of how the treatments should be given. So it's becoming more and more robust, and it answers how to diagnose, treat with algorithmic precision. And we've moved from stage and treat to identify the driver and match the therapy. So this is what we are moving towards. And they have also emphasized that how we can integrate new science, AI tools and mechanisms in as we move on for a dry practice to make the outcomes even more better. So talking from diagnostic perspective, from signs to symptoms, we all know that the first and foremost would be the clinical signs, the what we look at on the slit lamp, whether the patients have any redness or not, to look at the cornea in detail, whether you find the cornea is clear or not. If you find anything suspicious, you do have tests like staining, and staining can be lissamine green staining or just a fluorescein staining, which can give you a lot of information whether there are any erosions or not. What is your tear film breakup time, whether it's stable tear film or not. And it can just, this is the first step where it can tell you whether you should be, what direction you should be going into, whether it should be evaporative dry eye, aqueous deficient dry eye, or a mixed type of dry eye. So anything we go into advances or don't go into advances, we have to remember that these 4 tests are still the gold standard. The Schirmer's test, the fluorescent green staining, the T-BUT, and the tear meniscus height. And this we get it on slit lamp. If we do it appropriately, we do get, as I said on the first step itself, that what is going to be your, what you should be looking at, what should be your next step. And whatever happens, this is always going to be the gold standard. And we all know how to do a Schirmer's test, the T-BUT test, ocular surface staining, and tear meniscus height. So I'll not go into details of each of it. But before doing any of this test, you shouldn't label the patient as what type of dry eye it has, whether it's dry eye or not. Tear film breakup time also with the fluorescent staining can give you a lot of answers. If there is a complete area break, that means you're dealing with severe aqueous deficiency. If you find this a spotty break, that means it's a decreased wettability. A random break can be a sign of increased evaporation. If you see this line kind of a break, that means it's mild to moderate aqueous deficiency. And if you see this dimple kind of a break, it means mild to moderate decreased wettability. So a tear film breakup time test can give you a lot more information of, again, what type of dry eye it is, whether it's evaporative or aqueous or mixed. The second thing which comes across very handy and which doesn't cost you at all are the questionnaires. And the questionnaires can be anything but the OSDI, which is the Ocular Surface Disease Index, the DEQ-5, which hardly takes less than a minute for the patients to fill and for us to analyze, and the quality of life vision, 25 vision questionnaire as well. So this three has always been there, and it tells you whether the severity of dry eye, and whether it's impacting the quality of vision or not. However, the OSDI has been the most reliable one, but it was little it's little trickier when it comes to taking the patients with this questionnaire. So this time they have simplified it, and from 12 questionnaires they've reduced it to 6. And based on the 6 questionnaire, you can give a total of what is a total. If it's less than 4, that means it's normal. If it's more than 4, that means you're dealing with some sort of dry eye, and that's when you go into the investigations. So this is the cutoff of the different questionnaires. As mentioned before, the most important ones would be the OSDI, and if you're looking at the post cataract or refractive surgery, it would be the quality of life vision questionnaire. But otherwise, all the questionnaires are equally good, and it gives you the information about evaporative, non-evaporative, inflammatory, non-inflammatory. So the questionnaires also help you a lot, and it doesn't cost you anything. So these are the most basic tests you should do in a dry eye patient for the diagnosis of it. And this is again the OSDI questionnaire, which was mentioned before. Now, moving forward from the diagnostics of basics to a little bit more advanced, the second tool which helps a lot is the meibography in dry eye diagnosis. Meibography is something where you can look at the health and the density and the quantity of the meibomian glands, because that again helps a lot on where your treatment should move to. And it is done using an infrared imaging to visualize the meibomian glands inside the eyelids, both the upper and lower lids. And it can tell you whether there is a gland dropout or not, whether there is a truncation or shortening or glands, whether there is a tortuosity or irregular gland patterns. And it tells you whether there is MGD or not, it confirms, and it also tells you the stage of it. Now, when it comes to meibography, it just not only gives us the information. Now, sometimes when it's a grade 1 or higher form of MGD, you do have to give patients, and if there is an inflammatory component, you may have to start this patients on a little bit higher dose of anti-inflammatory drops, which could be a cyclosporin or trehalose. And if it's a very severe form, you may have to do a procedural therapy like Meboflow or Lipiflow or IPL therapy. So when you tell these patients, the patients do get scared about, why I just have a little bit of complaint, why should I do all this therapies, and which is going to cost me a bomb. But if you show them this meibography results, you can educate them on why a certain treatment, why are you advising this treatment. You can tell them what stage of disease they are in. If they don't take the treatment, or if they're not compliant, what can happen. Because a lot of times we have this issue of dry eye patients, when they put a drop, they feel better, and then they become non-compliant. So the meibography can actually help us to educate our patients on what disease we are dealing with, and why we have to give a certain treatment or not. Then there are other modalities like a lipid layer thickness, where you can see the knee bud, the eye blink, the density of the lipid layer, the tear film meniscus height, and the meibomian gland also. And based on that, you can give a scoring of what kind of dry eye you're dealing with. It's mild, moderate, or severe as well. It can tell you the health of lipid layer, the density of lipid layer, and if for any reasons you cannot do a T-BUT test, a knee bud test is more or less as good as T-BUT. So according to the DUCE 3, first it has to be symptom screening, along with asking the symptoms to the patient. do the Schirmer's, TBUT, and all the general tests, the basic tests. Use a validated questionnaire, and based on that, you can classify the patient whether it's aqueous, evaporative, MGD, or mixed. And if you want, you can also do one of this tear film homeostatic marker tests, which are more objective, which can be done either with TBUT, a tear osmolarity, which is not really needed. If you have done a good TBUT staining and meibography test, it gives you most of the important driver, and based on that, you can identify the dominant driver to guide the management pathway. So that's how it helps. And if you're dealing with a classic patient of dry eye, this is how the algorithm should be. And if any postgraduates are attending, this is just a simple flow chart of how you look at the Schirmer's, TBUT, what should be the values, and based on these values, how will you classify them as aqueous deficient, meibomian gland dysfunction, or mixed type of dry eye. So this is just a simple chart of how to classify the patients in each of this category. The second thing which helps a lot on a slit lamp examination is the test for MGD, where you just, if you press the lower lid or the upper lid of the patient over the central third of the lids, you can check for how the expressions are, whether the expressions are there or not. If there, what is the quality of the expressions? If there are any blocked gland orifices or lid margin signs present or not. So a simple test on the slit lamp also helps to see what type of MGD you are dealing with, whether it's a mild form or a severe form, the percentage of blocked gland orifices, and etc. So this also helps us a lot in our practice. Now, I'm not going to go deep into it, but again, this is from TFOS 3. You can go and refer it. It's freely available online. Based on, if you have a dry disease patient, there's always a thing of differential diagnosis. So based on the eyelid-related disorders, the conjunctiva-related disorders, the non-ocular surface disorders, or any cornea-related disease, what differential diagnosis you should be looking at before you advise the patient the dry therapy. So that is also very important. And these are the three things, the three algorithms of tear film deficiencies, eyelid abnormalities, and ocular surface abnormalities. Basically, what could be the etiologic driver tests you should be doing. And based on that, if it's a lipid layer deficiency or aqueous deficiency or a mucin deficiency, what kind of treatment you should be giving. So you should look at the tear film deficiencies. Then there are eyelid abnormalities as well based on your blinking rate, the anterior blepharitis, MGD, gland dropout, lid keratinization, demodex infestation, also what you should be your treatment. And if it's an ocular surface abnormality, then you have to classify what is the etiologic driver test or condition, and based on that you advise the therapy. So this is again a part of TFOS DUCE 3, how you should look at if you're looking at the advanced dry eye. But otherwise, if you're looking at just the simple dry eye, how to treat it, I'll come to it next. So this is again from TFOS DUCE 3 management algorithm. It's a tired one. If it's the first stage is tear film deficiency, just a deficient dry disease, you just start the patient on simple CMC based drops. But if it's moderate or severe, then you start on anti-inflammatory like cyclosporin or lifitegrast. If it's an evaporative dry disease, if it's a baseline, what to do if it's an ocular surface inflammation, or if it's a lid or blink exposure related disorders. If based on the mild, moderate, and severe stage, how should be the therapy, it tells you that. But the emphasis here again is start low, escalate as per the severity. Now again, we do have lot of lubricants, and always there's a question of what lubricant to give at what stage. This is again this time given clearly in TFOS DUCE 3. When to give aqueous-based tears, lipid-based or emulsion-based tears, mucin or hybrid tears, what type of drops to give for what kind of patient, what is the characteristics, the pros and cons, and have very clearly been given, and when to use the preservative-free formulations as well. Now, if it's an aqueous deficient dry eye, if it's a mild, you just give an aqueous based lubricant like CMC or HPMC. But if it's a moderate, then you add a HP Guar fortified based tears or a sodium hyaluronate based tears, because it gives increased hydration, and consider gels at bedtime. And if it's severe, then you consider the high molecular weight or cross-linked sodium hyaluronate based drops, and also the gel at nighttime. So focus on tear replenishment and osmoprotection as well. If it's an evaporative dry eye, start simple just with hot fermentation. If it's moderate, then add an omega-3 based supplementation and lid hygiene. But if it's severe, then you definitely have to consider a procedural therapy like for MGD, like a Meboflow or a LipiFlow or IPL therapy. So here you have to focus on lipid replenishment, plus also taking care of the lid hygiene. Now, if you have a mixed mechanism like aqueous or evaporative, then you have to use a sodium hyaluronate based drops or trehalose based drops, and also look at a nutritional support in form of omega-3 or vitamin D. And the goal here is to use hybrid tears, which mimics the full tear film, which is the aqueous lipid mucin layer, for better stability and comfort. If you're looking at the mucin layer instability, then here you have to think of a vitamin A based therapy, because here you have to aim for mucin addition plus epithelial regeneration. And if it's a nocturnal dryness or legophthalmos, then you have to use an ointment in the night, and tell the patient to tape their eyelids while sleeping, so that there is no evaporation or corneal based condition. Now, if it's again a special scenario of dry eye like post LASIK, contact lens intolerant, digital eye strain, all of this again has a different perspective of how you use the drops for each of them. So if you have any of it, then you have to look at a high molecular weight drop like a sodium hyaluronate, or if it's a contact lens intolerant or post LASIK smile dry eye, you have to look at a procedural therapy also. And in a severe dry eye, always look for a preservative-free formulation, or if the patients are allergic, or if they have any ocular surface stinging or burning sensation, then also use a preservative-free formulation. Now, as mentioned before, if it's a moderate to severe dry eye, then you earlier the better. You have to look at now one of the procedural therapy. It's not that you have to look at it, but if you have an access to it, then in India now we have 4 procedural therapies like LipiFlow, EI, iLight, and Mebothermoflow, which can treat the diseases at the right time for giving patient a better quality of life. And especially if you're taking up the patient for a cataract or refractive surgery, the patients, if they're not ready to wait, then this procedure works quite well. Now, how does this help? We all know that if there is MGD, there is a lesser lipid concentration stressed, which leads to abnormal inflammation and nociception. And if you do one of these dry eye therapies, it reduces your obstruction, it increases the quality of secretions, makes your tear film stable, reduces the stress on the ocular surface. It reduces the cytokines and unhealthy cytokines and chemokine production, giving a normal ocular surface. And it also improves the blood circulation by dissipating the blood vessels, improving the secretion of anti-inflammatory cytokines. So doing this dry eye therapy, if you have an access to it, or if you have a patient whom you feel it will benefit for him, then definitely go for it. Now, all the procedures are different from each other. Like LipiFlow is a thermal pulsation therapy where it's heat and massage on the eyelids. However, the biggest concern since the time it's been introduced is the cost. It's quite costlier and it's a single use applicator, so you can't even keep redoing it. And sometimes with one visit, the patients may not benefit. So here the concern is the cost. The IPL therapy also is a very good therapy because it's a broad spectrum light applied to periocular inflammation. Typically 4 sessions are required 2 weeks apart. However, it works more better when the patient has an ocular rosacea or telangiectasia, or it improves the TBUT and meibomian gland quality. However, it cannot be used for patients with darker skin, or patients with any previous treatments, or patients with a lot of lid abnormalities. So it is better for patients with ocular rosacea or telangiectasia or any refractory inflammation. But however, if the patient has dry skin or a darker skin, then you should avoid doing that. Coming to MeeboFlow, it is also a heat-based therapy. It is an external heat therapy. You have to give like I'll show you the procedure, but it's a 40 to 43 degrees of temperature, which gets generated in a handheld silver plate, and you have to manually massage the upper and lower lids for 10 minutes. You can vary it. It varies from 8 to 12 minutes per eye, and it's usually given in three sessions, spaced 2 to 3 weeks apart. And one of the advantages of this is, though it's manual, but the results are as comparable as LipiFlow, which has been the gold standard over a short mid-term when used as a multi-session protocol. It's a gentle warm massage where no anesthetics are required, so you actually feel like a spa-like experience. It's very safe. Rare cases of epithelial disruption, but it's not been noted in our concern. But the good thing is it's a very cost-effective treatment because it has no consumables or licenses. So it's a very cost-effective treatment. You can offer it to more and more patients, especially the ones going for surgery, because it gives faster outcomes. Now, what would be the ideal candidates for these patients? Any candidate with evaporative dry eye due to MGD, dryness, burning sensation, grittiness, fluctuating vision, or contact lens intolerance is also one of the key factor where you can advise this treatment. Also, patients with rosacea, this can be used. Patients with blepharitis, it works very well. Patients for Demodex also, it works very well. So it helps you a lot for many cases. Only places you should not use it as if there is an active lid infection or inflammation, then you treat them first. And if it's an advanced gland atrophy, then none of this therapy works. So for those patients, you probably don't need it. But otherwise, this would be the most ideal candidates. And I already spoken about, you can also use it in adjunct to the refractive or cataract surgery patients. Experience wise, even with one sitting, a lot of patients from burning, blurry vision, and heavy dependence on drops, they feel there is an improved comfort, vision stability, and reduced need of drops, and the burning sensation and everything also reduces. So the patient shouldn't be wearing any contact lenses or makeup, because otherwise during the massage it can go inside the eye. You apply a coupling gel, and you preheat the handpiece and make the patient have comfortable seating, and then you can start the therapy for doing the massage over the eyelids for 8 to 12 minutes, and 3 weeks apart, 3 sessions 2 weeks apart. And you can give a maintenance dose after the 6 months of the 3 sittings. It also works very well. And after that, if it's a moderate or severe dry, the patients can continue the warm compresses at home. Otherwise, it's not needed. And the literature says that the OSDI and the speed questionnaires typically improve by 30 to 35% from baseline after one sitting, and there is an improvement evident within weeks, sustained for often to 6 months. Also, the meibomian gland secretion and the expressibility improves. The meibomian quality shifts from toothpaste-like thing to clearer and thinner, good quality of fluids. The T-butt increases also, and the tear osmolarity reduces. The conjunctival and the corneal staining gets better. The durability, as said, it can last as good as 6 months, and there are no serious adverse events reported in studies. Minor or transient lid edema or puffiness is possible, but that is just transient, and by evening or next day, the patient looks better. So it's comprehensive, safe, and sustained improvement in dry eye disease, and it can be used for as many patients as possible, especially preoperatively and for contact lens discomfort. Now, these are some case scenarios. This was the work. This is work done at NN. Here, again, this is a patient who's seeking an opinion for refractive surgery. You can see that everything looks fine, but the OSDI scoring is on the higher side, and the epithelium also looks unhealthy. And when doing the detailed tests, you can see that the tear film hardly is present. That is, the white regions are absent tear film. This is an unhealthy or a very thin tear film. And the red means also a bad tear film. And you can see that there is a little bit gland tortuosity also. And after the MeeboFlow therapy, you can see the quality of tear film improves. The tortuosity also reduces. The gland is never going to come back. The lost glands or the dead glands, they don't come back, but the tortuosity can get better. And if there is any lid edema or anything which is hiding your glands, you may start seeing glands in a better way. So it's not the glands have started growing. It's just that lid edema has reduced, and that's why you see the quality and the quantity of glands in a better way. And the OSDI also improved from 55 to 20, and all the other parameters also improved in terms of quality of vision. And this is a pre-MEBO flow. You can see how the quality of vision in terms of the point spread function and the visual frame breakup time was. It's all in red. However, post just one sitting of MEBO flow, you can see that the quality of the breakup time and also the vision has improved. This is again a second patient whose OSDI is on the higher side, and patient is wanting to undergo refractive surgery. So same thing was done. One sitting of MEBO flow was done for this patient. And you can see a similar trend of improvement for this patient before and after surgery, making the patient healthy for a refractive surgery. Now, everything said and done, you've done everything, but we do have patients who always keep complaining about pain, and we do not know what is missing. So one of the things what we have to look at is the pain without stain. And it is not just, you cannot identify on any of these tests, but it's a little bit on the advanced side. And that is why you cannot make out, because it's reached the level of peripheral and central sensitization. And the typical patients complain of is anxiety. They have a lot of mood disturbances. They are non-compliant to medications. They don't have, even if they put drops, they don't feel better. And this is the work taken from my mentor, Dr. Rohit Shetty, because he's of lately quite doing a lot of work on ocular pain. And he's just made this good cartoons of how, if you understand the peripheral and the central sensitization, the mood of the patient, when everything has failed, then you can treat the patient in the better way. And we all know that ocular, if the patients have pain without stain, if you don't treat it in the right way, it can lead to binocular single vision problems, where the patients start having focusing issues, eye pain, headaches, and everything. So, and that's what leads to depression and all. And these are just some pathways of the same. So identifying these patients at the right time and treating them with a gabapentin or a TCA would help. So when all the therapies fail and your patients are still thinking of pain without stain or complaining of pain without stain, then you look at the central or the peripheral sensitization and treat the patient not just with lubricating drops, but a gabapentin or TCA based on the level they are in. So when it comes to dry eye disease, you have to always think of practical integration, a layered dry eye disease algorithm. Start slow, but then go advanced if it's not getting treated. Set the expectations right, that it's going to be gradual cumulative improvement. A chronic condition requires maintenance. So it's just like your diabetes, that if you have dry eye, like how you take medications for diabetes every day, there is a possibility that for dry eye also you may have to need it every day. Also, the patients need a good chair time to explain what it is. And if they understand all this, it's effective, efficient, and patient friendly. The future is all about artificial intelligence in dry eye disease, because a lot of patients may have 100 complaints, and sometimes it becomes difficult to process it. So with the AI based softwares for automated diagnostics, tear film analysis, you can actually give a personalized treatment, and you can have a remote monitoring of how the patient is responding to your treatment based on the thing. Very severe cases of dry eye, there is a role of regenerative medicine for lacrimal gland regeneration, meibomian gland regeneration, which is still work in progress, but that is going to be the future for severe dry eye disease cases. Stem cell based ocular surface repair, we all know, but that's entirely a different topic. And nerve growth factors. So this is going to be the future of dry eye when it comes to the regenerative medicines. And these are all the emergent therapies, which probably would be in our clinic one day. So we are moving towards an era of personalized medicine. So you have to identify the patient, whether it's evaporative, aqueous deficient, mix, or any other category. And based on that, you have a ladder of lubricants to choose from, what condition the patient has, how you choose. And if the patient has moderate or severe dry disease, you go to one of the procedural therapies. If the patient is undergoing cataract or refractive surgery also, you ask the patient to, undergo a procedural therapy before undergoing the surgery. If the patient is not ready to wait, if the patient is contact lens intolerant also, then you ask the patient to do one of these therapies for an effective outcome, because the drops always may not help. So uh, dry eye is not just a CMC based drop, but based on the science, based on the symptoms, and with the newer algorithms what we have for diagnostics and management, even a simple test can tell you what kind of dry eye you're dealing with and what kind of medications or therapy you should be giving to the patient. And the future is all about the AI integrated precision diagnostics. So we are moving towards an era from subjective symptoms to objective signs towards a precision ocular surface care, and a true personalized medicine where one size fits all is moving towards tailored therapy for a better patient outcomes. So target the cause. There are proven benefits of all these therapies. So use it. They are safe and comfortable. They have comparable outcomes, and they are best suited for individualized treatment. Thank you.
Thank you so much, Dr. Pooja. In fact, this perfectly fits the need of our delegates who are registered here. Basically, these are general ophthalmologists and cornea specialists who are interested in practicing contact lenses. So there are a few questions that I have got from their portal. So I'll just put them through. Then we may invite Dr. Bhupesh also to join the panel. So, Dr. Pooja, one question is it practical to follow all the dues criteria and test in a busy OPD while managing dry eye patients?
The basic, as I said, it's must. Schirmer, Stibert has to be done. Look at the quality of the meibomian secretions, how they are antiophyll meniscus height. So that will tell you what direction to look at. One of the most important thing, even in a busy OPD, I would think helps us a lot is a scoring. So if you use a questionnaire, as I said, the DEQ5 and now the OSDI 6 takes less than 1 minute. So while the patient is sitting in your waiting room, if you know the patient has come in for dry eye, meanwhile the optometrist sees, or you see, or you take in the patient in your OPD, if you give them a questionnaire, by the time they walk into your clinic, it's ready. So I think these are the must to do tests in a busy clinic. And if you are average seeing 20 or 25 patients of dry eye a month, which are like not the mild ones, not those routine burning sensation ones, but the moderate to severe ones, then having a meibography also helps a lot, because it helps, as I said, it helps to educate the patient. So it's not that you have to do everything, but based on what kind of a patient you are treating, the severity of patient you are treating, you decide what diagnostics to do for your patient, and that based on that you decide the treatment.
Okay, another interesting question is how far is it practical to do? How far is it practical? It's the same question. And there is one extra point here. So, do you routinely stain all the suspected dry eye patients?
Yes. As again mentioned, stainings gives you a lot of information about the tear film quality. So if it's a
Which,
dry eye patient, then staining is must.
so, which stain you prefer? Is it fluorescent or Lissamine green?
Fluorescein for the basic dry eye or evaporative and aqueous deficiency, just to identify fluorescein is the best.
Which of the heat therapy? I think you outlined that slide, right? Three, four options. Which one is best according to you between
So
that? Yeah.
uh, So there is one of thermal pulsation or a thermal based therapy, and the other is IPL based therapy. As I mentioned, the thermal pulsation therapies works the best for evaporative and mixed type of dry disease. The LipiFlow, the concern is the cost, because it's the patient cost. It comes to almost 25 to 30,000 rupees. So if you have to ask the patient to do it again and again, it may not be very suitable. And also, I think now the company doesn't manufacture it anymore. So LipiFlow was the gold standard, but it has its limitations. IPL works very well, but IPL is not a thermal pulsation therapy. It's just a pulse based therapy. It doesn't produce heat on the lids, and it activates your parasympathetic system. So if you have an classic evaporative dry eye where your glands are blocked, where your secretions are unhealthy, then IPL may work maybe 30 to 40%, but not completely. But if you have any telangiectasia or those blood vessels you see on the lids, or any patient has rosacea with a light colored skin, then IPL works well. But if it's a classic MGD patient, or if it's a contact lens intolerant patient, or if it's a patient who's undergoing refractive or cataract surgery and has MGD, then Meboflow works well because it is cost effective also. So if you see cost wise, Mebiflow is the most cost effective, followed by IPL, followed by Lipiflow. So that's how it works the best. And one good thing is it doesn't have any side effects. So even if you have to repeat it more than ideal sessions are 3, but even if you have to repeat more than 3 or 4 times, it can work. And per sitting of Meboflow costs anything between 3 to 4,000. So it's quite cost effective, whereas IPL costs between 8 to 10,000. So this is how you choose based on what kind of patient profile you have and what type of patient you have.
So, Dr. Neha, normally you will have only one instrument at your setup. So there is, I think there are few centers where you have all the four choices and you have to decide which one to use. Okay, very important question related to this. If can these therapies be combined with cataract surgery?
Yes, but you have to keep a gap. If you're doing a cataract surgery, then and if the patient needs one of these therapies, you have to keep a gap of at least 7 days, I would say, for a cataract surgery. And if it's a refractive surgery, 3 days should be good, because when we do one of these procedural therapies, a lot of inflammation gets washed out. And if you do just within 3 days, it's an intraocular pressure, intraocular procedure, so there can be some challenges. So cataract surgery, 7 days gap, refractive surgery, 3 days gap should be okay.
And do you add steroid to your regimen if you are doing this before cataract?
It depends. If it's a mild or very early moderate grade of dry eye, then you don't need steroids. But if it's a moderate, where there's a lot of those toothpaste like of secretions or blocked glands, then steroids help before surgery. It reduces the chances of post-op inflammation.
This is a good question by Dr. Himanshu. What is the average time when the MGD resolves?
Um, so in 3 sittings, the patient's in the first sitting, the patient's symptoms improve by 30 to 35%. And mostly by the end of 3 sittings, they feel better by 60 to 70%. However, this procedural therapy are just to reduce the burden of lubricating drops or immunomodulators. It is not going to resolve your MGD completely in moderate to severe cases. So if it's moderate to severe, even after procedural therapy, you have to ask the patients to do warm compresses at home and use lubricating drops. But in mild cases, sometimes only a CMC based drop may help. So based on the severity, you decide how much improvement the patient is going to have, and whether the patient will need a post-op medication and what form of medication. But this just helps to basically, let's say if you give a lubricating drop, the patient may only improve by 10% at the end of 1 or 2 weeks or 1 month. Here it's 3 times. So the intensity is better.
Okay, now we are little bit changing the field. Somewhere is Dr. ASZ. I think YouTube name is different. So how commonly you see dry eye in pediatric patients and how to treat the MGD part in pediatric patients?
Very rarely, to be very honest. In children, it's increasing, but it's very rare still. A lot of children complain of burning sensation or stinging. Uh, do basic dry eye test to see whether they really have a dry eye or not, but always keep in mind a component of non-strabismus binocular vision anomaly, because whenever the patients have one of this, they may complain of eye strain and burning sensation, but it is basically the muscle issue and not the dry eye. So let's not overkill the patients with dry eye therapies, especially in children. With the increasing risk of myopia, again, There is work being done in NN where they're suggesting that inflammation can lead to increase in myopia. So yes, dry eye will be becoming more and more prominent as we move on, but not at this point of time. And if the patients have MGD in children, then first start slow and only if needed go higher up.
So yes, even at RP center also, we see dry in pediatric patients only in cases where it is associated with something else. For example, there are some systemic disease or patient had some viral erythema. But to see primary idiopathic dry eye is very rare in pediatric patients. I think this much is the questions from the panel. Okay, one more question. Any do you prefer any choice of IOL? Look, it's about the choice of IOL. Would you prefer multifocal IOL if the patient is already having dry eye before cataract surgery?
No. The first answer is going to be no. If it's a very mild form of dry eye, then maybe yes, but a very detailed counseling on the pros and cons and then only proceed. But if you personally ask me, the answer is always going to be no. Now we have a lot of options of EDOF IOL. So EDOF IOLs can still be thought about in a patient of dry eye disease after one of these therapies or after treating the dry eye, but avoid multifocal as much as possible.
Okay, I think most of the questions are related to these points only. Yes. Any genetic association? Normally we don't see that. Pooja, any experience? Somebody has any genetic association with dry eye?
Um, it's the
I think
answer is yes. The answer is yes, but I don't think we are there yet to talk about it. But the answer is yes. Maybe after 5 to 10 years, you will hear about it more. But at this point of time, what we have discussed, I think the role of biomarkers will be more prominent before genetics as we talk on.
Yes. I think that's the catch here. Rather than going for genetics, we should check for biomarkers here. And yes, I think we are done with the questions from our audiences. And one more thing, Pooja, they keep on sending question to us. So if we get any more questions, then I'll message you or
Sure.
email you.
Surely. Anytime.
Yes, this is not there. So I think it's already 8:20. We can conclude the session here. Thank you so much, Pooja.
Thank
And
you.
I hope you like this concept of webinar. We don't take anybody in the panel. We just keep the speaker and we keep our guest in another platform so that the speaker is free to talk whatever he wants. I hope you like the concept and I hope you'll join us in future webinars too.
Surely. Thank you for the introduction. And I think this helps you cover the whole topic in detail from basics to advanced.
And
Yeah.
also we get a lot of time to discuss. That's the best part. So the idea of all this Super Tuesday is one-to-one interaction. So initially we tried to take all our audiences on this platform only. Then there was a chaos. So we thought, okay, let's take them to a different platform, and this platform will keep only for the speakers.
No, I think
Okay,
this
there is
works
one
very
more
well.
question.
Yeah.
Do you modify the energy setting of IPL based on patient skin color?
So there is a color-coded card what the company gives. Basically, based on the color of the skin, you can match, and based on that, it tells you what energies to use. But it's just a graded one. You can't change too much. Whatever they recommend, we have used that only. We've not done any experiments there.
Yeah, welcome, Rupesh. I think you are muted because we have covered all the questions by the
Yeah,
audiences.
some
And,
basic, some few more questions I have for Pooja. I think Pooja has covered almost everything about dry eye, and I was listening patiently all the things that she was covering.
yes,
So
we
few
covered
things,
nicely the entire topic.
yeah. So few things like Pooja, you were telling about the vitamin A based solution in cases of mucin deficiency. So for the benefit of all of us, how to uh, diagnose mucin based deficiency dry eye? Because it's primarily aqueous based deficiency, we know, or lipid deficiency. So how to know that this patient has a mucin based deficiency?
Based on a little advanced diagnostic test like tear osmolarity, but otherwise at this point of time, you just do it clinically based on the T-butt, the quality of tear film on the fluorescent staining, or if you have a knee butt based on that. So that's when you decide. And if
Okay.
you have a patient whose tear film is evaporating very fast, even with a high molecular weight drop like sodium hyaluronate, then you can introduce a vitamin A based ointment for those patients just
Okay.
at night time.
Yeah. And one more thing is that we all are giving lubricants for months or years to all our patients nowadays. So any long-term problem with these lubricants like sodium hyaluronate or with other CMC or any special compound that we should be very careful while giving for a prolonged duration.
One thing what we have seen sometimes is that not, maybe 1 or 2% of the patients are allergic to sodium hyaluronate. Sometimes they come back saying, when I put this drop, I have redness. When I used to put CMC, I never had redness. So there is only 1 to 2% of the patients who have that. And that's when you have to change the drop, either go to preservative free or go back to CMC plus gel or one of these procedural therapies. But otherwise, there is no side effect of giving sodium hyaluronate or along with tree halos also for a very long time. If nowadays you have to be very careful, some of the drops come with vitamin D. So if you're giving with vitamin D, try to stick to 6 months and see if there are any changes on the ocular surface on the negative side or not, and then decide to continue. But the topical vitamin D, we do not have much of experience of how long it can be given. But otherwise, there is no uh, there is no hindrance. Also, a lot of times we have seen cyclosporin is given to VKC kids or dry eye patients for 3 or 4 years, nothing happens. So apart from vitamin D, I think you don't have any challenge of how long it should be given.
Okay. And
Lipitigrast is something which should be given for 3 months to begin with and maximum 6 months. And then if it doesn't work, then you have to switch to a little advanced form of therapy.
do you do OSDI in all your cases of LASIK and cataract preoperatively?
No, we do the Shermers and T-butt, but the OSD is not done for all the patients until unless they complain something about contact lens intolerance, or they say when we are sitting in our chamber, we have burning sensations. These are the signs of subclinical inflammation, but otherwise just Shermers T-butt.
Okay. And how early we can do IPL post cataract surgery? Because managing the post cataract surgery dryness is the most challenging for all of us because patient is not ready to listen to anything.
It's IPL, like the pulse-based therapy, then you have to wait for at least 4 weeks, any of the therapies.
Okay. And when you use cyclosporin in cases of post LASIK patients, in which cases, how you choose your patient that this needs cyclosporin and post-operatively?
If the patient has a history of contact lens use of daily contact lens use daily of 5 years or more, these are the patients who are at higher risk of the epithelial remodeling being erratic because their epithelium is not very healthy. And post-operatively, they may not complain of dry eye, but the epithelium remodeling may be like land up into hyperplasia or something, and that's when they may have pseudo regression. Sometimes we see that, or they're not very happy with quality of vision. So if there is a daily contact lens user for 5 years or more, we use cyclosporin for at least 3 months. Or if it's a known patient of dry eye to begin with before surgery, then cyclosporin for at least 3 to 6 months after surgery is mandatory. We use cyclosporin for all our patients of PRK because it reduces the early inflammation, chances of haze. The epithelial remodeling again is quite better, so it reduces the chances of pseudoregression. So these are the three conditions we use it always, but otherwise it has to be case to case basis.
Thank you, Pooja. Thank you so much for all the answers.
Thank you, sir. Thank you.
Pranita, do you have?
Sir, yeah, if you have time, I will ask just
Yeah,
one
yeah.
question, sir. Yeah.
Is that the same question from message or what?
No, sir, different one. Okay. Hi, Dr. Pooja. I just wanted to ask you that sometimes we have more complicated situations like cicatrizing conjunctivitis with severe dry eye. What are the conditions in which you use autologous serum or any experience with the use of topical insulin or topical heparin in the use of these patients and management of these patients?
Autologous serum, we've had quite a lot of experience and it works very well. for all these patients. But of course, they have to keep coming back to you to get the drops made. But otherwise, it works very well. And TFOS Deuce 3 also addresses that. Because it was very advanced, I didn't cover it, but that addresses that there is no harm in early introduction of autologous serum in cicatrizing keratinization patients. Insulin drops is also becoming more and more, spoken about, and it has a very good role, especially outside of India. We've heard promising results when it comes to insulin drops. So hopefully we will start using it soon, and we will have the same benefit. But we need companies to make good
commercially
quality.
prepare it and make it available for everyone.
Yes. So those two are the future of dry eye disease management.
Yeah. Thank you, Dr. Pooja.
And Pooja, I was sparing you with 10 minutes still left, but I think Pranita and Bhupesh, they didn't like the idea. So they extended till 8:30. And this is a normal time when we finish our webinar. So thank you, Pooja. That was a wonderful discussion part. And I hope it will benefit all our delegates who have registered for this contact.
Thank you for inviting me once again.
No, that was a pleasure. And it was just
Thank you.
That means I think somebody approached you, then he came to me, would you like to have Pooja? मैंने बोला अरे तो पूछ क्या रहा है, just call her. We want her and a speaker.
No, thank you so much. DOS is always a good meeting to be around.
Yes. Thank you for that compliment.
Thank you. Thank you.
Let's end here. Good night, Pranita. Good night, Bhupesh. Good night, Pooja. And
night.
thank you, Sarik.
Good night.
For hosting the meeting.
Good night. Good night, sir.
Right.